Sir, we are going live in 3, 2, 1. We are live now.
Good evening, Dr. Lakshmi. Namaskar. Congratulations.
Thank you, sir. So all your blessings, sir. Thank you, sir.
Thank you. You are yourself a great man. You deserve all this. So, if it is now live and open, somebody is introducing from Intouch side.
Yes, sir. I am introducing. I am Mayank Sharma.
Man, please.
Yeah. Shall I start?
Yeah.
Yes, please. Please do that.
Okay. Sir. Good evening, ladies and gentlemen. I welcome you all for this 51st episode of Secret of Neurology, the knowledge feast for all neurologists. A warm welcome to all the faculty from Guntur Government General Hospital. Today's presentation is on very interesting topic, lost vision and involuntary motion, a neurometabolic syndrome. Hello.
You are audible. Go ahead.
Diksha, please change the slide. A warm welcome to our course directors and all the faculty members of today's session. These are some details of the flow of event for today's session. It's an honor and privilege to introduce our course director, Dr. Sudhir V. Shah, sir, Professor and HOD, NHL MMC and SVP IMSR Ahmedabad, and Director of Neurosciences, Sterling Hospital, Ahmedabad. Sir has many association and affiliation in the field of neurology. Sir is consultant neurology to HE, Governor of Gujarat, past executive member of Indian Academy of Neurology and advisor to World Yoga Foundation. Sir is having an immense contribution in the field of neurology. Dr. Sudhir sir is author of 6 books on neurology, public education, and several publications at state, national, and international journals. Sir has many accolades, awards, and achievements in his name. Just to highlight few of them, in June 5th, 2024, Sir awarded as French Senate the highest international award for Indians, conferred with the most prestigious award of our country, Padam Shri in 2016, Dr. B.C. Roy Award in 2018, and recipient of UNO Award and Global Visionary Award. And we have seen Sir interviewed by various international and national TV channels like CNBC, BBC for his famous research on prolonged fasting, and featured in 3 international documentary films. Sir has a special interest in the field of stroke, neurodegenerative disease, and epilepsy. Welcome, sir. It's an honor and privilege to introduce our another course director, Dr. Lakshmi Narasimhan Ranganathan, sir, Director and Professor, Department of Neurology, Shri Ramchand Institute of Higher Education and Research, Chennai. Sir has many awards and affiliation in the field of neurology. Sir is Pelatusi Advisor from AN 2007. Sir received A.B. Becker Award for Global Best Teacher, Best Paper Award from the American Academy of Neurology, Executive Committee Member for World Federation of Neurology, Licensure Officer for World Federation of Neurology since 2009, Member of Public Relation Committee for World Federation of Neurology since 2014. Sir has immense contribution in the field of neurosciences, 3-term executive member in IEN, CME convener in IEN, and Sir has successfully organized 7 consecutive clinical neuroscience programs for all India DM Neurology postgraduate from 2010 to 2017. Welcome, sir. Now, I just would like to hand over this session to our course director to take this forward. Thanks, sir.
Thank you, Mike, for that kind introduction. With this, I want to thank, first of all, Guntur Government General Hospital, the Department of Neurology headed by Dr. U. Aruna Kumari, and Dr. M. Bhargavi Devi, who is the assistant professor. And today the case presenter is Dr. Bhanu Chandra Prasad. So Dr. Bhanu Chandra Prasad is the second year DM Neurology resident from the same hospital, Department of Neurology, Guntur Medical College, Andhra Pradesh. And he had done his MBBS from Kakatiya Medical College, Warangal, and MD General Medicine from Mamta Medical College, Khammam, Telangana. Next slide, please. The case will be discussed thoroughly further by Dr. M. Bhargavi Devi, who is the assistant professor in the same Department of Neurology. And she is MBBS from Guntur Medical College, MD General Medicine from the Guntur Medical College, and she did her DNB Neurology from Lalita Super Specialty Hospitals at Guntur. So, welcome Dr. Bhargavi Devi. And the most prominent person from the department, the HOD and Associate Professor, Dr. U. Aruna Kumari will do conclusion and give final summary and remarks. She had worked as an assistant professor in the Department of General Medicine, Osmania Medical College, Hyderabad, and then assistant professor in neurology at the Andhra Medical College, Visakhapatnam. She has academic background of MBBS from Rangarayan Medical College, MD from Siddharth Medical College, Vijayawada, and DM from Andhra Medical College, Visakhapatnam. Now, as you all know, today they will be presenting a case of lost vision and involuntary motion, a neuro metabolic syndrome. So there is a twist here, neuro. Anyway, I want to bring to your notice some important thing, and that is, as you know, we have crossed the important milestone of 50 consecutive programs, webinar on secrets of neurology, that is knowledge feast for all neurologists. So this is 51st episode in session program. Every month it is held on the last Friday, dot at sharp 8 p.m. and it goes on for about 1.5 hours. So I think this is a record in itself. Very few such webinars I have heard of in different parts of the country or world who would last so long, and still people take a lot of interest and keep on updating themselves. May it be students, maybe assistant professors, even professors and seniors, they also love to attend this online. At the same time, many do this on YouTube channel. So I think this is one of the most successful and most sought after series. And for that, I want to thank my co-course director, Professor R. Lakshmi Narsihan, who is a profound, knowledgeable personality, and heads off to him for his serious efforts for this program. And we have been very lucky and successful that all important medical colleges from all over India have participated in this program, and remaining will do so in the coming months. We wish to continue this program as long as you all take active interest and participate. And also, I want to thank all the previous medical colleges and the participants, right from student of DM and DNB to assistant professors, associates, and professors of the unit. So that is the key of success. I have to also announce and congratulate that our mentor, our co-course director, Dr. R. Lakshmi Narsihan, has been recently elected as the incoming president-elect for the Indian Academy of Neurology. Dr. Lakshmi,
sir.
congratulations.
Thank you, sir. Thank you,
And
sir. Thanks for your
all
blessings,
the
sir.
best.
Thank you so much, sir.
Yeah.
Thanks for your blessings. Thank you.
You deserve this and much more. So, most welcome. And I also want to thank all the participants who have kept trust in us all these years. We have completed 4 years now. And I also sincerely want to acknowledge the incessant and unrestricted support from Global Cell Division of Intas Pharmaceutical, headed by Mr. Chadda and his team, Dr. Shweta, Dr. Manoj, and the ground staff, all have worked very hard for the success of this program. So with that, I would like to hand over the mic to Dr. U. Aruna Kumari to present today's case. And Dr. Lakshmi, would you like to say a few words now that you are now going to be our president-elect?
Sir, thank you.
Please, that you
Sir,
say
thank
a
you.
few.
Thanks for your kind blessings. My sincere thanks to all the people who had belief in me, and my hearty thanks to every one of you. And in fact, Dr. Aruna, madam, I know her from Andhra Medical College times, and in fact, she volunteered to. She came to me and she said she volunteered that she wanted to present. So this kind of response is overwhelming for us, sir. So I'm very happy, looking forward to this interesting episode. And my advanced Diwali wishes to every one of you, which is going to be next week. Wish you all a very happy, merry, and safe Diwali. Thank you. Over to Dr. Aruna.
Yeah, I also want to extend my heartiest wishes for the Diwali and the year that is coming. May it bring all hope and happiness to each of you, and stay happy and safe. Thank you. Thank you, madam. Please take over. Thank you very much.
A very good evening to everyone. Thank you for giving me this opportunity, Dr. Lakshmi Narasimhan sir and Dr. Sudhir Shah sir. Today we are presenting a rare case. Only one case from India was reported till today. We searched in the literature and we found only one case. But in all over the world, some cases are there. But we'll go to the case. Sir, shall I ask Bhanu to present a case?
Please start.
Okay, sir. Thank you, sir. Over to Bhanu.
Sure. Good evening. Good evening, everyone. Thank you, Dr. Sudhir Shah sir and Lakshmi Narasimhan sir, for providing me this opportunity. Today I'm going to going to present the case of lost vision and involuntary motion, a neurometabolic syndrome. So I'll start with complaints. A 27-year-old male resident of Tenali, studied up to MA, informant being himself and his father, presented with diminution of vision, difficulty in walking, involuntary movements of both upper limbs since childhood, and involuntary movements around mouth since 6 months. Coming to history of present illness, he was apparently normal up to 3 years of his age. Then he had diminution of vision. His father's friend noticed that he has trouble with vision and asked him to take an eye doctor. He was taken to ophthalmologist, but no specific treatment was advised. He was unable to see small letters in childhood, but able to see the bigger letters. Progressively, he was unable to look even the bigger letters. History of difficulty in walking in dark. And he has a difficulty in differentiating colors. While watching TV, he used to increase the contrast of TV. Then only he is able to see the colors. He used to write bigger letters till 9th class. He used to go to regular school till 9th class, but unable to see the blackboard. So he was admitted to blind school. Then he used to listen and take the help of scribes to write the exams. Due to poor vision, he is unable to identify his parents. Only with the help of voice, he used to recognize his parents. So, and he searches for objects due to poor vision. While studying degree, he was operated at some private hospital for squint in left eye. Later, they felt that his vision was further deteriorated. And he sees static objects as moving. History of difficulty in walking since childhood in the form of buckling and falling, and had sustained multiple injuries. History of difficulty in climbing up the stairs initially. His father used to carry him for getting up the stairs. Later, difficulty in getting down the stairs because he cannot judge the distances and depth, and had a multiple falls. He feels stiffness of both lower limbs while walking. History of difficulty in crossing thresholds. History of difficulty in walking over uneven surfaces. Parents also noticed that he has reduced arm swing while walking. He closes his both fists while walking, but he was not slow in his daily activities. His father noticed that it is abnormal and started him on multiple supplements like spirulina, aloe vera, saraswati leaves, vitamin A and D, fish oil, cod liver oil. Later, they observed improvement in his walking. History of involuntary movements in both upper limbs in the form of dance-like abnormal movements involving hands and sometimes associated with posturing. They are present mainly during walking and other activities, aggravated during stress and anxiety, not present during rest, disappears in sleep, and not able to suppress voluntarily. These movements are associated with deviation of head to left side. History of chewing like oral and facial involuntary movements since 6 months, along with deviation of mouth to right side intermittently. Insidious onset, and these movements are insidious onset, gradually progressive, associated with jerky movements of head to one side, with frequent movement of tongue in and out, and these are not suppressible, disappears during sleep, aggravated during anxiety and stress. And there is no history of propulsion of food while eating. He also has sleep disturbances since 4 years. He usually sleeps at 11 p.m. and gets up at around 3 a.m. every day since 4 years. He shouts very loudly, involuntarily moves all his forelimbs. Sometimes he also falls from his bed. This usually starts at the middle of the night. He was completely unaware of this event, no post-ictal confusion or drowsiness. Sometimes he used to shout 3 to 4 times a night. No, these sleep disturbances are not associated with history of sleep paralysis, walking, and teeth grinding. No history of nightmares, excessive daytime sleepiness. He's able to raise his arms overhead, able to reach overhead objects, able to comb his hair. But he has a difficulty in mixing and eating food because of slippage of food from the fingers due to abnormal movements and posturing of hands. No history of difficulty in holding glass or spilling of water. No difficulty in buttoning and unbuttoning shirt. No difficulty in opening and closing the bottle caps. Able to feel close of the body. Able to differentiate hot and cold water. Able to feel mosquito bites. No band and girdle-like sensation. No electrical shock-like sensation and bending the neck. No difficulty in rolling over the bed. No difficulty in getting up from bed, and no difficulty in raising head above the pillow. No flabbiness or thinning of the limbs. No history of syncopal attacks or postural giddiness. No history of bladder and bowel disturbances. No history of loss of smell. And there is no history suggestive of cranial abnormalities. No history of recurrent headaches, vomitings, fever, seizures. No history of recurrent respiratory tract infections or joint pains. No history of shortness of breath, cough, rash, and any other swellings of the body. Past history, he was operated for left eye squint at the age of 17 years. His current functional status, he's independent in doing ADLs. He's able to go to Hyderabad in his hometown without accompanying person. Coming to birth history, he was born out of fourth degree consanguineous parentage with normal vaginal delivery, normal birth weight, no history of NICU stay. But he has a history of delayed milestones, both gross and fine motor. His mature prensile grasp at 16 months, bisyllables at 16 months, walking with support at 2 years, walking without support at 3 years, running at 4 years, words with meaning at 3 years. This is a pedigree chart. Actually, this is a fourth degree consanguineous parentage, but his father and mother has no idea about the previous generation consanguinity. Family history, most of similar complaints in the family, but his elder sister died at the age of 1 month after birth, probably due to sepsis. Personal history, takes mixed diet, normal appetite, disturbed sleep, regular bowel and bladder habits, and there's no addictions. Drug history, he's on multiple medications like coenzyme Q, Saraswati leaves, fish oil, omega-3 fatty acid, multivitamin capsules since childhood, around 5 to 6 years. Actually, his father did a lot of research about this his son condition, so he started using himself all this medication. Coming to summary, this is a 27-year-old male born out of fourth degree consanguineous parentage with no significant natal postnatal history, with history of early death of sibling, global developmental delay of milestone, presented with progressive loss of vision with significant oxalopsia. They noticed in the 3 years of age, along with involuntary movements in both upper limbs, suggestive of chorioathetosis with abnormal posturing and cervical dystonia, stiffness in both lower limbs with gait disturbances, NREM sleep disorder, that's confusional oral states, and orofacial dyskinesis since 6 months, without any sensory, cerebellar, cognitive decline, and features of raised ICT. So with this summary, the structures involved are global development delay with optic nerve and its pathway, basal ganglia and its connections, and pyramidal tract. With the history and the summary, my differential diagnosis first goes to complicated hereditary spastic paraplegia with SPG variants like 15, 16, 21, 35, 54, 56. And one more condition is HSP with optic atrophy, also called as Behr syndrome. And second is dystonia syndromes like DYT8, DYT9, and DYT29 variants. And mitochondrial disorders like LH1 plus, Leak spectrum, and OPS spectrum. One more differential diagnosis, juvenile Huntington disease, Wilson's disease, neuroacanthocytosis, NBIA, and DRPLA. So, first differential diagnosis, hereditary and neurodegenerative condition, complicated HSP. Points in favor of spasticity is present with visual loss and dystonia, but points against are no intellectual disabilities in, no dementia, and no distal myopathy. And dystonia syndromes, points in favor are spasticity, dystonia, chorioathetosis, vision loss in first decade. Coming to mitochondrial, points in favor are multi-axial involvement, engage, vision loss in first decade only, and spasticity along with chorioathetosis. But it has no family history, no seizures, and no ataxia. Coming to juvenile Huntington's, spasticity, dystonia, chorioathetosis are favor, but no cognitive and behavioral problems, no seizures, no family history. Wilson's disease, spasticity, dystonia, and age less than 40 years of age. But against are most commonly seen in second decade, but no psychiatric manifestations is seen. Coming to DRPLA, chorioathetosis, dystonia, ataxia in favor, but no cognitive decline, no seizures, and no family history. Coming to NBIA, chorioathetosis and dystonia, neuroacanthocytosis, there is no feeding dystonia, sleep disorder is seen here, no behavioral, no cognitive decline, and visual loss. Points are these are against for neuroacanthocytosis. Coming to examination, first we'll go to general examination. Patient is conscious, coherent, and obeying commands. Modality built and nourished. No pallor, icterus, cyanosis, clubbing, lymphadenopathy, edema. Coriform movements of both upper limbs are present. Cervical dystonia, orofacial dyskinesis is seen. Inappropriate laughter is seen. But no evidence of nerve thickening, no neurokeratinous markers, no evidence of self-mutilation, and no cave ring. So videos have been shared after taking informed consent from the patient. This is a video for just general examination. Tonia with normal posturing and chorioathetosis movements of the both hands, along with orofacial disconnections. You can see the tongue movements also. Intermittently, they move in and out. Kinetic movements. And this, while performing examination, you can see these both hands chorioathetotic movements. Coming to vitals, temperature is 98.6, pulse 78 beats per minute, irregular, normal value, normal character, condition of vessel was normal. Blood pressure is 110/70 in right upper limb supine position, respiratory 18 beats per minute, abdominal thoracic type, and saturation is 100%. Coming to ECG, there is an irregular atrial fibrillation was noted in his ECG, but with controlled ventricular rate. Coming to neurological examination, higher mental functions. Is a right-handed person with MMSE 28/30. He studied up to MA, but he studied in a blind school. He has lost 1 point in reading what we wrote and lost 1 point in copying intersecting pentagon because of the poor vision. His speech is nasal twang with mixed dysarthria.
చక్రవర్తి రాజగోపాల్చారి.
Actually, he has a nasal twang with mixed dysarthria with mild spastic component. Memory, immediate, recent, and remote memory is intact. Visual memory could not be done. Verbal memory intact, and new learning abilities intact. Semantic memory intact. Frontal lobe, insight present, judgment present, fund of information is intact, and there is no abnormalities in response inhibition. Trial making A and trial making B could not be done because of the poor vision. Frontal leaf signs are present, both grasp, snout, boat, and rooting and palmometal are present. Coming to left parietal lobe, no apraxia, no finger agnosia, no right to left confusion, and calculation is intact. Right parietal lobe, no hemineglect, line bisection is able to do, clock drawing could not be done, construction apraxia could not be done, and no dressing apraxia. Occipital lobe, his visual acuity is counting fingers from half meter only. Visual field is decreased in all fields. Color vision is impaired. This visual agnosia, prosopagnosia, simultagnosia, visual disorientation, optic ataxia could not be done. Cranial is olfactory is on both sides is normal. Optic now, visual acuity is counting finger from half meter. And fundus is a bilateral optic atrophy. Color vision unable to identify colors. Coming to 3, 4, 6 now is no ptosis. Pupil is normal size reactive to light, but there's a RAPD present on the right side. Light and accommodation deficiencies are present on both sides. Extraocular movements, there's a nystagmus on both sides. We'll see the coming slides. The broken pursuit, and he's unable to fix the gauge in both eyes. Okay, and both horizontal and vertical is lost on both sides. Coming to 5th now, Jajaki present. You can see the eye movements. This video is not primary gaze. It's unable to fix the gaze. You can see nystagmus in the primary gaze only. Searching for objects. Searching nystagmus is there, large amplitude. Pursuits is unable to follow because of the poor fixation.
Left చూడు, right, left, right చూడు,
It's
left చూడు.
large amplitude searching jerk nystagmus due to poor vision is seen. We can see the fundus bilateral optic atrophy. Coming to 7th and 8th now normal, 9th, 10th also normal, 11th is normal, 12th now bulk normal, power normal. These coriform movements are seen in the tongue and no fasciculations in the tongue. Motor system examination, attitude comfortably lying in supine position, bulk equal on both sides, no evidence of atrophy or hypertrophy. Coming to tone, upper limbs, the spasticity grade 1 is seen in both right and left, and lower limbs grade 2 is seen in the right side and grade 3 is seen in left side. Power is normal in both upper limbs and also in the lower limbs. We can see the milkmaid grip is present. Power is normal, hand grip is normal. So normal. Coming to reflexes, corneal, conjunctival, abdominal reflex present. Plantar is extensor on both sides. Jarjacric present. Biceps, triceps, supinator is 2 plus. In the lower limb, knee is 3 plus and ankle is 3 plus. Without clonus. Extrapyramidal system. Chorioethanoid movements along with dystonic posturing in both upper limbs with cervical dystonia, orofacial dyskinesia, Negro and Froment sign negative, finger tap and toe tap test is negative, blink rate is normal, Myosin signs is negative. Cerebellum, speech is nasal twang with mixed dysarthria, no titubation, nystagmus we already seen, finger nose and finger touch intention tremor with post pointing is seen, dysgenicokinase present in the left upper limb, rebound phenomenon is present, knee heel test is impaired, toe finger test unable to perform, tandem walk is impaired, and there is a pendulal knee jerk on the right side. Sensory system, touch, pain, temperature, JPS, vibration, cortical sensation is intact on both sides. Gait. The punctal and cervical dystonia with chorioethanoid movements. Mild ataxia. Summary. 27-year-old male born out of 4th degree consanguineous parentage with no significant perinatal, natal and postnatal history with global developmental delay of milestone, history of early death of sibling, presented with progressive loss of vision at the age of 3 years with bilateral optic atrophy, spasticity in all 4 limbs with brisk reflexes in the lower limbs and extensor plantars, chorioethanoid movements with dystonia in upper limbs, cervical dystonia, orofacial dyskinesis, pseudobulbar effect and cerebellar involvement without any seizures, sensory, cognitive decline, and features of raised ECT. After examination, my differential diagnosis are again first place goes to complicated HSP with the variance 15, 16, 21, 35, 54, 56, and dystonia syndrome, mitochondrial disorders, DRPLA. We can add SCAR 3 and 7, 3, 7, and 17, and juvenile Huntington disease, neuroacanthocytosis, and NBIA. Investigations. Complete blood picture is normal. Electrolytes, sodium, potassium, chloride is normal. Creatinine 1, blood urea normal. Bilirubin virus are negative. TSH is normal. Serum CPK is 22. INR is 1.27. Vitamin E and CSF lactate are normal. Vitamin B12 is normal. Nerve condition studies is normal recorded in all 4 limbs. ECG atrial fibrillation with controlled ventricular rate. It's a peripheral hemogram with smear. There is no acanthocyte seen on the smear. Normocytic normochromic RBC. Coming to 2D echo, this is AF during the study is noted with no conduction abnormalities and no valvular abnormalities, no systolic or diastolic dysfunction. CT abdomen. Actually, in CT abdomen, is left kidney is not seen in the left renal fossa. In the lower pole of left kidney is fused with lower pole of right kidney anterior to abdominal aorta, crossing midline at level of L2, L3. And rest of the abdomen is normal. And impression is horseshoe kidney. His VP is prolonged in both sides. P100 is prolonged in both sides. Coming to MRI, MRI suggests is normal actually. There is no hyperintensities or abnormalities in the basal ganglia. No cerebellar atrophy is seen. So with this, we as these investigations are not suggestive of this any other diagnosis, so we went out to whole exome sequencing. So it came out to be disease is 3-methyl-glutaconic aciduria type 3 and it is likely pathogenic with variant is chromosome 19. So this 3-methyl-glutaconic aciduria type 3 is caused by mutation in the OPA3 gene and due to defective chromosome 19q. So my diagnosis, this case is 3-methyl-glutaconic aciduria type 3. It is also known as Kosteff syndrome. Thank you. Next, I'll hand over my session to Bhargavi madam for discussion.
Good evening, all. This is the case presentation. Shall we proceed with discussion? Or any questions from the panel?
Shall I start, madam?
Wait, Bhargavi garu, wait a minute.
Okay.
Sir, good evening, sir. Lakshmi Narasimhan, sir. Sudhir Shah, sir. Shall we move on, sir?
Thank you, doctor.
Hello.
Sir,
Hello?
shall we move on? Or
Yeah,
any
yeah, please move
questions
on.
at this point?
Ask for the assistant professor to discuss.
Yes, sir. Good evening, all, sir. I'm Dr. Bhargavi. I'm going to give a brief account on the discussion of the present case. It was diagnosed after genetic analysis as a Kosteff syndrome. It's a neuro-ophthalmological genetic disorder. It's a type 3 methyl-glutaconic aciduria. The disorder is named after Hanan Kosteff, who first described the syndrome in 1989 in 19 Iraqi and Jewish population. It's an autosomal recessive disorder caused by mutation in the OPA3 gene. This OPA3 gene carries instructions for the synthesis of the gene product, the OPA3 gene. The exact function of the product protein is unknown. It plays a integral role in the mitochondrial function. So you have some problem.
Your screen has been shared now. You can proceed.
Yes, ma'am. So it's an the hallmark is increased urinary level of the 3-methyl-glutaconic acid and 3-methyl-glutaric acid. The urinary testing, it will allow the diagnosis as early as 1 year of the age. The genetics and function of OPA3, all patients with of Iraqi Jewish origin are homozygous for a split site found in the mutation in the OPA3 gene. This is mapped to chromosome 19q, 13.2 and q13.3. Several cases have been reported since then, almost exclusively of Iraqi Jewish origin only. This founder mutation is a G2C mutation of a single nucleotide which interferes with gene expression level of the OPA3. This OPA3 protein is an integral protein of the mitochondrial outer membrane and it had a role in mitochondrial fission and apoptosis. This mitochondrial OPA3 is shown to protect the electron transport chain against inhibitory compounds. Clinical features. Characteristic clinical features are early onset bilateral optic atrophy, later onset spasticity, extrapyramidal dysfunction, ataxia, cognitive deficit. OPA3 defect may also cause autosomal dominant optic atrophy with cataract. Patients with Kosteff optic atrophy syndrome are similar to Behr syndrome. Behr syndrome is a hereditary spastic paraplegia with optic atrophy with ataxia. So the important difference between these two is ataxia is regarded as a necessary component of Behr syndrome and some patients of the Behr syndrome may have peripheral neuropathy. But in many of the type 3 patients of Kosteff syndrome, ataxia was absent. If it is present, it was of mild degree. Neither clinical or nor electrophysiological evidence of peripheral neuropathy was seen in Kostev syndrome. So a distinction between the two syndromes is supported by the lack of 3-methylglutaconic aciduria in patients with Behr syndrome of non-Iraqi Jewish descent. So there is a defect in the metabolism of the branched chain amino acid, mitochondrial leucine catabolism. In the mitochondrial leucine catabolism, the intermediate product is 3-methylglutaconic acid, which gets accumulated in this disorder. Types of 3-methylglutaconic acidurias. 5 distinct types have been recognized. 3-methylglutaconic aciduria type 1 is an inborn errors of the leucine metabolism. All other 4 types they'll affect the mitochondrial function through different pathomechanisms. Type 1 is through carried through the gene AUH and located on the chromosome 9. The main other name for this type 1 is 3-methylglutaconic aciduria type 1 or glutaconic acidemia or 3-methylglutaconyl coenzyme A hydratase deficiency. Because of this one, this enzyme hydratase enzyme is involved in the amino acid leucine metabolism. This leucine is broken down in the mitochondria during the process of energy production. In type 3, the defective gene is TASH and it is located on the XQ chromosome. The other name for this type is Bath syndrome, where it will have the cardiomyopathy neutropenia syndrome. The gene provides instructions for making a protein called tafazin. This protein plays a critical role in maintaining the level of the particular lipid called as cardiolipin, which is located on the inner mitochondrial membrane. So lack of tafazin results in abnormalities in the structure and function of the mitochondria, and it will lead to cardiac defects. Type 3, it is located on the gene OPA3 on the chromosome 19q, 13.2 and 13.3. It's also called as Kostev syndrome or type 3 methylglutaconic acidurias. We have discussed the function of this gene and the protein. Type 4 is also known as type 3-methylglutaconic aciduria type 4. Type 5 is 3-methylglutaconic aciduria type 5. Diagnostic approach to the patient who presented with 3-methylglutaconic acidurias are depending upon the clinical scenario, whoever are presented with the features. If the patient had leukoencephalopathy, more in favor of type 1, then we have to go for genetic testing. Next, if the patient had optic atrophy, he may have type 1 or type 3, and ataxia and spasticity, type 1 and type 3. And cardiomyopathy, liver failure and bone marrow failure features. In our case, the patient had optic atrophy with ataxia and spasticity, but he had AF but without any cardiomyopathy or other bone marrow suppression features. So, in the specific test was genetic testing. The treatment. In primary 3-methylglutaconic aciduria, due to 3-methyl coenzyme A hydratase deficiency, 3-MGA accumulates. So as happens in other organic acidurias, it may have a neurotoxic effect and it will cause cell death. In this case, leucine restricted diet can be suggested. It is the precursor amino acid of the interfered metabolic pathway. So it may have a therapeutic effect, but although the number of the cases diagnosed and treated is too small to draw the definitive conclusions. In other types of the 3-methylglutaconic acidurias, the excretion of the 3-MGA is secondary and it does not appear to be related to their metabolic defect. So therefore, the treatment of these diseases cannot be based on decreasing the formation of the 3-MGA, but it has only symptomatic and supportive treatment. Prognosis. The long-term prognosis of Kostev syndrome is unknown, though it appears to have no effect on life expectancy, at least up to the 4th decade of the life. However, movement problems can often be severe enough to confine the individuals to a wheelchair at an early age, and both visual acuity and spasticity tend to get worsen over time. So, when to suspect mitochondrial disorders clinically? When there are multiple sites of neuraxis involvement, onset is at very young age, worsening of the settings in high metabolic demand situations like fever, ataxia with or without cerebellar degeneration, early onset hearing loss, and retinal degeneration, optic atrophy, and ophthalmoplegia. So, thank you.
Thank you. Madam, your concluding remarks.
Sir,
Yes, madam. Excellent presentation. And in the chat box, I saw check there is not many questions in the chat box. Most of them are. So I think Madam will conclude.
sir, this is an autosomal recessive disorder caused by mutation in OPA3 gene. The OPA3 gene may play a role in protein synthesis. Exact role is not identified till now, and mitochondrial function is dependent on this gene, though the exact role has not been identified fully. Clinical characteristics of multi-axis involvement in the form of early onset optic atrophy, spasticity, extrapyramidal ataxia, and cognitive deficit. Having important difference as a complicated HSP, Behr syndrome, or other complicated HSPs. Ataxia and cognitive deficit are mild or late onset in many cases of Kosteff syndrome, whereas ataxia is a prominent feature in Behr syndrome, along with spasticity and optic atrophy. All the Kosteff syndrome cases are reported in the literature till now are from Iraqi Jewish population, except 2 case reports we found in the literature. One is from Turkish Kurdish origin and the other is Indian origin. This may be probably because of migration of the Jewish people to different parts of the world, especially to India and to Turkey. And the possible reasons for less number of reported cases may be as the disease is recessive in nature and the gene may not be expressed sufficiently to manifest the symptoms in many cases. And recent advances in genetic testing may identify more number of cases from other than Iraqi Jewish population in coming years. As the defect is in a single gene, gene therapy may be effective in the future. So we thought of presenting this case as it is a rare case, one thing, and the single gene defect. So genetic testing is available and gene therapy may be available in the future. So these are our references, sir.
Thank you. Thank you for a wonderful.
Thank you, sir.
Thank you for a very wonderful case, madam. The first time I am hearing about this. As you rightly said, the advent of CRISPR-Cas9, the gene editing technology, where there's a huge lab of about 600 crores being set up by Tata Group in Sriperumbudur near Chennai for gene editing, and they are already successful in editing the single gene in sickle cell anemia, and that is why government has also launched the gene editing for sickle cell anemia. So I think for monogenic gene defects, we are not far away from cure. So I think whenever my message to younger neurologists that after the advent of the genetics of the testing in neurology, the neurology will be rewritten. I'm sure the entire things will be rewritten, and a lot of newer things you are likely to see. And all of you should concentrate on approach to most of these neurogenetic disorders and start using how effectively use the various options which are in front of you, starting from Sanger sequencing, or doing a clinical exome or whole genome sequencing, whichever test what is applicable, the least economic stress to the patient, you should be able to identify this. Another interesting thing is, the genetic tracing back on the generations, which is another useful, very interesting journey. They trace back to as many generations as possible from the family to find out when did the gene migrated from Jews to India. As you said, it's probably inherent in that population. It could be a mutation or it could be a transfer across the when during migration, the genes could have been transferred many generations back. And in fact, even a few people did take that the historical genetics tracing studies are also now quite interesting. Thank you, Dr. Bhanuchandra Prasad, for a wonderful presentation. Dr. Apurva Devi had excellently discussed, and my personal thanks to Dr. Aruna Devi for giving us such an intellectual feast on this Sunday. And I found there's no questions on the chat box. There's 1 minute. Let's check the last question. Good case from the Department of Guntur Medical College. Very good. There's somebody's appreciation is there, and no other questions. And Madam Sir is there now. Dr. Chari.
Sundarachari sir is in Machilipatnam, sir, at present. As a principal, additional DME principal.
Oh, very good.
He will come to Guntur Medical College principal in 1 or 2 days, sir.
Oh, Kanai, my regards to him. And I know that this department owes a lot to Dr.
Yes, sir. Yes, sir. The department is well established by sir.
Yes, I know Dr. Sundarachari, a very great academician, and I have a highest regard for him. Sir, Professor Sudhir Shah, sir, any comments?
The sir has to go somewhere.
Okay, I hand over to the organizers. Thank you so much, everybody. I organize the to the INTAS people for conclusion. Thank you.
Diksha madam, 1 minute. Shall I talk 1 minute?
Yes, please.
Actually, Ellen sir is my examiner, and sir asked me about mitochondrial origin of the mitochondria, etc. in my DM examination. I am very interested to know all those things from that time, and the incident
Madam,
is also mitochondrial.
It's a great tribute to me. Thank you so much.
Thank you, sir.
Madam, in fact, the mitochondrial DNA, interestingly, yes, as you know, the mitochondrial DNA, there is a theory that it has all come from the bacteria.
Yes,
the
sir,
bacteria, yes. The genome is neither present in father nor present in the mother. So if you really look at the evolution of the mitochondrial genome was or lastly from few of the bacterial mitochondria is only present in the mitochondria, and even though the inheritance is maternal, the gene composition is not from mother or not from father. There are few unique sequences which are present only in the eukaryotes. That's what is. So, in other words, they comfortably sit in the energy factory of our body and enjoying our life and sucking our life. The bacteria. That the theory is called endocytoplasmic theory in the mitochondrial inheritance. So that was quite interesting. Anyway, thank you so much for a lovely case, and thank you for acknowledging. Madam, thank you. God bless you. Thank you.
Thank you, sir. Thank you, one and all.
Thank you.
So thank you so much, sir. Good evening, all. I, Sirish MV, Senior Sales Head, on behalf of INTAS Pharmaceuticals, I would like to extend our heartfelt thanks to the esteemed speakers and course directors for making episode 51 of the Secrets of Neurology an enlightening and impactful session. Our deepest appreciation goes to course directors Dr. Sudhir Shah sir and Dr. R. Lakshmi Narasimhan sir. We would also like to express our sincere gratitude to the team of Guntur Government General Hospital, GGH, for their valuable contribution. I'd like to thank Dr. Bhanuchandra Prasad sir for the excellent case presentation, which added practical depth and clarity to the understanding of the condition, lost vision and involuntary motion and neurometabolic syndrome. Thank you, Dr. Bhargavi Devi Madam, for your in-depth insights and discussion on lost vision of involuntary motion and neurometabolic syndrome, and your expertise shed much needed light on the challenging topic. Also, I'd like to thank Dr. U. Aruna Kumari Madam for providing an insightful summary and conclusion of the session, helping us to understand core takeaways more clearly. Thank you all for your time, dedication, and the sharing of your knowledge to the neurology community. We at INTAS Pharmaceuticals are privileged to support such initiatives, and we eagerly look forward to episode 52 of this enriching series on 29th November. Thank you, sir. Thank you, madam. Thank you all for the time given. And once again, happy Diwali in advance to everybody. Thanks.
Thank you, sir.
Thank you, sir.